Oh, there's that recording. Thank you all so much for being here. We are so excited to be giving this briefing and for just how many folks have been energized around this topic and how just evidenced by the registration list today. So really appreciate you all being here. A couple of housekeeping notes before we dive in. On the next slide, we're recording this call. We will share the slides with you afterwards. And then we've disabled the chat and Q&A. We really do appreciate all of the questions that came in on the registration form. And so we'll have a chance to answer some of those questions today. And if you have any other questions that come up, we want those. So please send those our way at curiosity@wonderforgood.com. And we would love to take on those questions there. All right. So before we dive into the content today, I'm going to turn it over to Valerie Rochester, Chief Program Officer with Community Catalyst, to say a few words on Community Catalyst's behalf.
Thank you, and good afternoon, everyone. As was mentioned, I'm Valerie Rochester. I am with Community Catalyst. I'm the Chief Program Officer there, and it's really nice to be able to be on this call with everyone and to be able to share this space. And I really would like to take a moment to just talk a little bit more about what I do at Community Catalyst. I oversee the work that we're doing around our technical assistance and programmatic work, and have had the great privilege to do this with partners like yourselves that have been working across the country for over 25 years. And I have a pretty extensive history myself of doing this type of work and leading and working in the nonprofit advocacy space, and excited to learn so much more about what everyone on this call is doing and finding out more about the excellent work and the impact that we all are having. And this actually brings us, to the topic that we're talking about today, and the work that was co-created by Community Catalyst, Wonder for Good, and our partners that are working on medical debt and affordability, which is such a crucial issue, and to understand how to effectively communicate with policymakers and health system leaders and create buy-in for reforming healthcare in the country. And we're really grateful to the partners that have dedicated their time and effort to work on this very important issue and making the connections to the audiences that we all know are so important to this work. And it's really provided fruitful information, and we really appreciate the fact that everyone's taking time out of their busy schedules to sit on the panel this afternoon and share their perspectives. And I really appreciate the opportunity to have these few moments to say hello and share a little bit about myself and the work that we're doing, and look forward to connecting in a little more detail fairly soon. Thank you very much. And I'll turn it back to Wonder for Good. Thank you.
Thank you so much, Valerie. Really appreciate that. Just to say a few words about the Wonder team. My name is Caroline. I am here with my Wonder colleagues today, Nadia, Susie, and Carolyn. You can see them also on the call. We are just so grateful to have worked so closely with Community Catalyst these last few years. About Wonder, we specialize in deep audience research, narrative change, and messaging strategy, particularly at the intersection of health justice, economic justice, immigrant rights, and many other pressing issues of today, some of which you can see here on the slide, and just a few ways that we do that. And so what we're going to accomplish today on the next slide, we are going to be sharing the results and recommendations that came out of a several months long research project to better understand how we can persuade health system leaders and policymakers to support policies that will advance our health and economic justice goals. We're also going to be sharing concrete messaging guidance to strengthen your communications. And this will be grounded in research that we conducted with health system leaders and policymakers from across the country, across ideologies and political leanings. And then we are going to pivot to our panel discussion, and we'll hear from three great advocates who served as research advisors on this work, representing Florida, Maine, and California, and we're very excited to hear from them. All right, I'm going to keep us moving. On the next slide, we want to share just a little bit of background information about the research that we'll be talking about today, which inform these messaging recommendations that we'll be sharing. So the purpose of this project kind of came from a few reasons. So one, we know that health and economic justice are often positioned as these siloed issues, but really we see them as two sides of the same coin. So for example, rising out-of-pocket costs and dismantled protections lead directly to mounting medical debt and just additional financial strain on people all across the country. And so as we're seeing these renewed threats to health and economic protections, we and Community Catalyst really saw the need for a unified, compelling narrative that reframes these issues as systemic failures, not personal misfortunes or individual failings. And so to do that, we conducted research with health system leaders and policymakers, because we know that getting buy-in from leaders, like Valerie was saying, is essential to changing the policies and practices that are shaping health outcomes in our communities. And so while we're talking about these audiences specifically today, if you're curious to learn more about messaging to voter audiences, particularly those who are persuadable or conflicted, we will drop a link in the chat to research and messaging recommendations for communicating with that voter audience specifically on health justice. And then also just want to note that this project was guided by some expert advisors who are representing Community Catalyst partners from a range of states, working on a range of different focus areas, all united in these health and economic justice goals. And so I want to give a big thank you to them, including our panelists today. On the next slide, a bit about our research methodology. So Wonder conducted 26 in-depth research interviews between November 2025 and April of this year. We spoke with a range of health system leaders like hospital CEOs and Medicaid admins and policymakers. We interviewed a handful of these folks twice and others just once. And that gave us a really deep understanding of how of their views and what makes messaging persuasive to them. We recruited from a range of states to reflect various political leanings and contexts. So you'll see red, purple, and blue states reflected here and on the subsequent slides. So I want to note a couple things about messaging objectives before we keep going. So on the next slide, when we are messaging to health system leaders and policymakers, we are focusing on two primary objectives. So we want to activate target audiences who are already supportive. Maybe they're not quite as vocal as we would like them to be, but we also want to persuade audiences who could be more adamant supporters. We also want to move them towards activation, or maybe in the persuasion category, we're also focusing on folks who are a little bit more conflicted. There's something holding them back from being an active advocate. There's also a place for neutralization communication. And what that means is just when we're focusing our communications on neutralizing opposition, for example, moving people from vocal opponents to dissenters in the background. But we know that we are in a very difficult health policy landscape at the moment. And so the strategic goals of this project were to focus our resources on the audiences who are most promising. So you'll hear us refer back to this language, activate and persuade, and we want you to keep this in mind for your own messaging too. All right, a note on measurement on the next slide. So in this research, we wanted to measure levels of support on specific policies that align with Community Catalyst's broader health and economic justice goals and vision. And so we're doing that because we want to understand what messaging needs to do to build that support. We worked with the research advisors and with community catalysts to develop and prioritize a long list of both short and long-term policy goals, some of which you can see on the slide. These included things like lowering out-of-pocket costs, expanding the comprehensiveness of health coverage, advancing state-funded coverage for immigrants, universal government-funded health insurance, and several other goals. And I want to say that these goals and this list were meant to be a sampling of the many goals that we are collectively working towards. If you're on this call here today, you might see some of your goals reflected here, and you might be working on some slightly different goals, and that's okay. The learnings from this research can definitely still be applied to your work. And with that, I'm going to turn it over to my colleague, Susie.
Great. Thanks so much, Caroline. Hi, everyone. My name is Azucena Flores. I go by Susie. Thank you so much for being here. I'm excited to share what we learned from our research with healthcare leaders. I know that's why you're all here, so don't want to keep you waiting. I'm going to be moving pretty quickly to ensure we get to everything that we want to cover today, but as Caroline said, we will share the slides after, so you can spend more time with the material. So with that, let's jump right in on the next slide after this one. This is a summary of what we've heard across all of our research interviews. I'm going to start with a quick overview of all 7 findings. We're going to unpack each one a bit, and then we're going to get to recommendations. So number 1, everyone agrees the healthcare system is broken, unaffordable, and inaccessible. There's already agreement there. Number 2, big transformative fixes feel like the right answer, but they also feel out of reach. Number 3, incremental solutions feel more feasible, but support varies, with notable alignment around hospital accountability among public health system leaders. Number 4, politics, rising costs, and coverage losses are creating urgency to act, and for some, also creating a strategic opening to reconsider potential solutions. Number 5, responsibility is tangled in a web of obligation, of blame, and deference among key players. Number 6, new and unexpected messengers can help us cut through and increase the credibility of messaging. And finally, framing change as a shared responsibility can inspire hope and motivate action. Let's dig into each one, starting with finding number 1. Everyone agrees the healthcare system is broken, unaffordable, and inaccessible. This was one of the clearest findings, regardless of sector, regardless of geography. Our research participants consistently described the system as unaffordable, overly complex, and driven by profit. The implication here is so important. We don't need to spend time convincing the audience that there's a problem. That's not the point they need to be persuaded about. They already agree. But you don't have to take it from me, though. You see it there reflected in this quote from a private health system leader in a red state. The corporatization of medicine, the corporatization of healthcare, insurance companies, their primary objective is to maximize profit. That means maximizing denials, delayed payment. It's gamesmanship toward the goal of profit. Please note what you're seeing today is an abbreviated set of quotes and research because of time. The full messaging guide summarizing this work has many more quotes that support each of these findings, including this one. This perspective that the system is broken came through consistently over and over again across interviews. Number 2, big transformative fixes feel like the right answer, but they also feel out of reach. Many of the research participants that we spoke to were drawn to the bold solutions that we were sharing and talking about, particularly universal or single payer healthcare, because they address what they see as the root problem, profit-driven incentives, as we just saw on the previous slide. But at the same time, they're also deeply, deeply skeptical that these solutions are even possible, politically feasible, even at all achievable. So in other words, incremental reforms are often viewed as mismatched to the scale of the problem and not worth pursuing because they do not address those root causes. So we're seeing a central tension here. Solutions that feel big enough don't feel feasible. Solutions that feel feasible don't feel big enough. Let's check out this quote from a private health system leader in a publicly funded system from a blue state. "We don't have universal coverage. That's the problem. I need a magic wand to make universal happen. So in the meantime, do we do these incremental things that provide some value, but that don't really address the issue?" Again, really hearing that tension and that skepticism come through. Number 3, sort of related to this one, incremental solutions feel more feasible, but support varies with notable alignment around hospital accountability among public health system leaders. While support varied across the solutions we tested, Caroline showed the slide with our solutions. Solutions aimed at lowering costs are the ones that received the strongest support across all three of the different audiences we spoke under this healthcare umbrella: policymakers, private health system leaders, and public health system leaders, though many also want all of the details, right? Like, how are we going to do this? One notable area of especially strong alignment was greater hospital accountability among public health system leaders. That looks like enforcing community benefit standards, scrutinizing tax exemption misuse, regulating healthcare mergers, establishing a cap on hospital prices. This quote is an example of why. Hospital price growth historically has been off the rails, and there really aren't any good comprehensive tools that we have to rein in those costs. Businesses are paying higher premiums, and consumers are paying way more. So we see how many see rising hospital prices as a key factor in driving in the higher costs we're seeing and the reduced access to care. Moving on to finding number 4. Politics, rising costs, and coverage losses are creating urgency to act, and for some, a strategic opening to reconsider potential solutions that were maybe previously seen as completely off the table. Many of the research participants we spoke with described operating in a crisis-like environment right now, with rising costs and recent or anticipated cuts putting additional strain on the system. At the same time, even while navigating this crisis-like environment, many see this moment as creating an opportunity to revisit solutions that have previously felt out of reach. This quote from a public health system leader in a blue state captures that perspective. In the next 5 years, will single payer be very seriously considered? I think so. I think anybody who's not getting ready and figuring out what side they're on is missing it, because these costs are out of control. States cannot afford insurance. Employers cannot afford health insurance. It's going to cause a very loud outcry when people on Medicaid lose their coverage, and all the downstreaming impacts will cause it to come in a major way. Again, we see for some the mounting cost pressures, the coverage losses. That's going to create the demand needed to seriously consider larger reforms, or at least that's their view. Moving on. Responsibility is tangled in a web of obligation, of blame, and deference among key players. Some of the research participants we spoke with described, a system where responsibility is very diffuse. Different stakeholders tend to point to someone else as responsible for high costs or barriers to coverage. We also heard that many of these leaders feel constrained in what they feel they can publicly support. So, for example, we heard that some said they wouldn't get ahead of their leadership. I'm not going to get ahead of my governor, for example, or speak beyond their organization's position, even if they personally agreed with something. This quote from a private health system leader in a publicly funded system in a red state captures that dynamic well. Absent a universal solution, different groups are going to feel singled out. If we talk about financial eligibility standards for hospitals, they're going to point to insurance companies or to government payers. You've got the different entrenched interests that can point to each other and resist universal reform. Moving to number 6, new and unexpected messengers can boost credibility of messaging. Caroline mentioned earlier, we conducted 2 phases of research. The first is focus on mindset. We're simply taking the temperature. We're not trying to persuade. The second is based on those learnings and focused on persuasion. We think of that as, rather than taking the temperature, that second phase is the thermostat, identifying where we can make adjustments and shift attitudes. And we do that through message testing. One of the clearest findings that came from this message testing is that who delivers the message matters just as much as the message. The messenger can make the difference between someone paying attention or dismissing the message altogether. And we tested a range of messengers. Participants were especially receptive to unexpected voices, or voices that they hear less from. That includes employers, physicians, and other health system leaders, because they brought added credibility. These messengers were seen as understanding the real world constraints and trade-offs these leaders are navigating, rather than simply making a moral argument. Messages were particularly persuasive when these messengers shared why they changed their thinking on a solution. We call that a change of heart story. That's modeling how change happens, and at the same time giving others the permission to do the same. This quote from a private health system leader in a publicly funded system in a red state captures that well. Coming from someone who's within the system, advocating that point of view makes it a little bit more trustworthy, a little bit more believable. And finally, framing change as a shared responsibility can inspire hope and motivate action on the next slide. Despite the challenges we heard from these healthcare leaders and the fact that some even expressed a level of compassion fatigue, they didn't say it that way. That's how we saw it. These healthcare leaders consistently refer back to their commitment to patient outcomes as a major factor in their decision making, and respond positively to messaging that demonstrate and affirms how proposed solutions are grounded in that shared value. Many also appreciate the recognition that no single person, no single entity or stakeholder can solve these issues alone, and that meaningful progress will require shared responsibility across the healthcare system. So despite the fatigue we're hearing, despite the complexity we're all navigating, many research participants expressed a sense of optimism after engaging with the test content, which to us suggests a strong appetite for sources of hope and opportunity to take action. This quote from a private health system leader in a red state captures that sentiment well. It's going to take everybody. That includes legislators and hospitals and doctors and community leaders. We need to all sit in a room. It should be non-political. Healthcare should never be political in any shape, form, or fashion, and public health should never be political, but it is. Let's build from what we agree on to try to come up with a solution. So those are the 7 key findings from our research with healthcare leaders. I know I'm moving quickly. I hope you're still with me. So what does this all mean for our communications, for our messaging? What are the key takeaways? The so what, the recommendations, which we've organized around these 5 principles you're seeing. Build trust, acknowledge complexity, calm concerns, nurture compassion, and inspire hope. Let's unpack each one and how they can guide our messaging. Build trust. What do we mean by that? That means lead with shared values around healthcare and feature messengers who can name their motivations for speaking out and share their care and compassion for patients, communities, and consumers. This is going to establish common ground and openness. Building trust is all about inviting people in rather than solely calling them out. We want to affirm health system leaders and policymakers' shared goals of creating a more functional system that better meets patient needs. And whenever possible, we want to use and cite well-respected, politically neutral sources or sources that are viewed as politically neutral. Examples include KFF and JAMA to strengthen credibility. We saw stronger responses when information came from trusted sources like that, including among audiences across the political spectrum. So that to us really underscored the importance of being strategically neutral in our messaging over ideological signaling. Number 2, acknowledge complexity. Name the barriers to change that we just talked about: profit incentives, fragmentation, differences across states, and administrative complexity. So we don't appear to be oversimplifying the problem. When we rely solely on moral arguments and don't show that we understand the difficulty and challenges that folks are navigating, we risk being dismissed and as overlooking the constraints that make change difficult. So acknowledge that major structural reforms may not be feasible in the short term. And when we do talk about incremental solutions that are very important, connect them to a broader vision for a better healthcare system and explain how meaningful progress often happens through smaller practical steps that can build toward that larger change that we all see as needed. So the key takeaway I hope you're taking from here is that show that we understand the complexity of the system and the constraint that folks are navigating, while also connecting the dots between smaller steps and longer term change, so incremental solutions aren't dismissed as insufficient. Calm concerns. The goal here is to make solutions feel worthy, concrete, and achievable. That means grounding ideas in evidence, showing what impact we can expect, helping people understand how solutions work in practice, including who needs to be involved and how different actors would be effective. Whenever possible, use examples. That includes examples from other states, promising pilot programs. Do the work and share them. We can't just explain why change is needed. We need to show the how. We call this show, don't tell. It also means reframing government's role as a tool for problem solving by pointing to specific examples when coordinated action has worked across different levels of government and political context. Next, nurture compassion. We've shown that we understand the complexity of the problem. We're not oversimplifying it. Now the goal is to bring the humanity back into the conversation. Healthcare leaders are deeply motivated by improving outcomes for patients. So stories, testimonials, and real experiences can make the stakes of these issues more tangible. Again, showing, not just telling, why solutions matter. We also nurture compassion by having messengers, especially peer messengers, decision makers, share moments when their own thinking has evolved, explaining what they learned, what changed, what they experienced that changed their perspective is going to help normalize reconsidering long held views. Rather than making people feel called out or judged, it's going to create space for empathy and create curiosity and reflection and greater understanding of the experiences of others. And finally, activate hope. This is not just woo-woo advice. The goal here is to shift from spending more time describing the problem and more time on the solution, showing a path forward. Remember, we saw there is already agreement that there is a problem. We might see the path forward differently, but there is already agreement there's a problem. We do not need to spend a lot of time on that. We need specific solutions and we need hope. We often say hope is sticky, and healthcare leaders need hope too, not just voters. That means moving beyond what's wrong, offering concrete actionable steps for implementation, helping people see what they can do within their role, and highlighting examples of peers taking action. Most importantly, we want to connect solutions back to those shared values, like improving care for patients and building a healthcare system that better serves communities. Many of us, we're doing the hard work toward equity outcomes, right? And those goals really matter. But equity is the outcome we're trying to achieve. It's not always the best message itself. Effective messaging is going to focus on values and solutions that are going to resonate broadly past partisan lines while still advancing equity. That's a lot to take in. Over to my colleague for the next section.
Thank you, Susie. So we've talked about what we've learned from the research and what are the messaging principles for what you need to do to connect with your audiences, to activate and persuade those healthcare system leaders and policymakers. I'm going to cover some more details about the strategies to use and show you some examples of messages that were really effective. So first, we'll go to the messaging strategies. Start with incorporating those recommendations, those messaging principles that Susie just walked us through into all of your messaging to ensure that it meets the needs of your audiences. And we have to remember sometimes as advocates, what we want to hear, what resonates with us, doesn't always resonate with or move or persuade the audience that we need to reach. So consider ways to tailor your the recommendations that we've just gone over to your unique context, to the audience that you're reaching, to the political context in which you are operating. Second, messaging strategy is to build a portfolio of different types of content to meet different needs. So there's no silver bullet here. There's no one message. There's not a single word or phrase. There's not a single story that is going to persuade and activate the decision makers and policymakers that you are trying to reach to advance health and economic justice. But what we found worked really well is when we had a variety of different kinds of content. That could be case studies, policy briefs, those patient stories that Susie just started to talk about. Op-eds can work, fact sheets, a wide range of different kinds of content that helps to amplify the messages that we are trying to move forward to reach our audience. The third strategy is to deploy a diverse set of credible and unexpected messengers. So many of you probably already use or engage with these different kinds of messengers, like patients and consumers. Consider also from the testing we did, it was very persuasive for people to hear from unexpected messengers like employers, doctors, medical professionals, nurses, others that work in the healthcare system, hospital system leaders who are with us on many of the goals that we are trying to advance may be effective and unexpected messengers to their peers. And particularly, it was really important, I think, for people to hear from people across the spectrum of political ideologies who are willing to speak out. So someone who maybe is more moderate or conservative, who has had a change of heart on a particular issue, or has evolved their thinking about one of the solutions, can be a very powerful messenger because of that change of heart story. And then the fourth messaging strategy is to use examples and proof points about what actually works in order to reinforce what's feasible, and a legitimate solution. Consider drawing examples from a range of geographically and politically diverse states, so that there's the opportunity, that your examples are not dismissed by someone in one place who says, oh, well, that would never work in a place like mine. And that is important. Susie mentioned earlier this idea that you want to show, not tell. So showing how solutions and policies have made a difference for patients, have lowered costs, have addressed medical debt. Those examples of how policies actually work are very important to this particular audience that we're trying to reach. And then our fifth and last strategy is to segment your audience whenever possible. So consider how your messaging can focus on the key concerns or constraints that hospital system leaders face, if that's who you're trying to reach, or state Medicaid officers, or insurance commissioners, or policymakers. They all are in that tangled web of obligation and blame. And so to the extent that you can segment your messaging to reach a particular audience to address those concerns and the complexities they are contending with, that can be very, very helpful. So with that, what I'm going to do is show you a couple of examples of content we tested so you can see what it looks like. And when we share the link to all of the tools and resources from this project, you'll have access to these actual test examples. I should just note, these are these were developed for test purposes only. So they're not, this example here, for, the state policy brief was not a piece that actually appeared in JAMA, but we presented it as an article of the kind of content that could appear in a place like JAMA to see if that would resonate. Although the examples that we used were all real examples. So this was in a trusted healthcare trade publication. It highlighted real world examples. So we had examples from New York, North Carolina, Illinois, and Colorado. The specific policy solutions are real policy solutions that reduce patient financial burdens. And what we were able to do through this piece is show what is already happening in somewhere else and is feasible, it is financially responsible, and is scalable. This also included quotes from patients and consumers, a variety of different kinds of health system executives and leaders, and including public health system leaders. So I'll say a little bit more about because it's too small for you to read on the screen. You will get a link to this. What worked about it was the fact that these were real examples of solutions that have been implemented in a range of different kinds of states, that have different geographies, that have different populations, and also represented different political contexts. So both kind of blue states and also purple states. People were particularly very interested in the example from North Carolina, providing medical debt relief and mitigation. It included these short testimonials, as I mentioned, from diverse perspectives. And it was important for people to hear, to read those testimonials about what is working about the particular policy solution in that state. And again, it was in a trusted source, and that's really important for us to consider. And why it worked, it was a great example of showing, not telling. So it's proof that a solution is possible, and that is really activating hope for the policymakers and health system leaders who otherwise are navigating such complexity and may need to see these examples in order to feel like there's something they could do themselves. It really equipped them to think about a specific idea that maybe I want to try this, or it sparked curiosity for someone who was less familiar with what's already happened in another place. During the interviews, we even had people pausing and saying, hey, hold on a second, I want to go look this up, or I want to write this down because this actually is something we might want to pursue in our state. So this is a really good example of content in your portfolio. I want to show another example, which is a patient testimonial. This is a very common type of content and messenger and message that many of you as advocates are probably already using. I will tell you about this one that we tested. It was an emotional patient story that traced the journey from cancer diagnosis to treatment. And it highlighted how misaligned financial incentives in the healthcare system are shaping care for someone who's facing a cancer diagnosis at every step of the way. What worked about it is that it was emotionally compelling. It reminded the system leaders that we were talking with about the patients that they care about. So that was a very important part of the story. We paired that story with this exploration of the misaligned financial incentives in the system to highlight the systemic nature of the problem. We highlighted that people often think about costs before thinking about their cancer diagnosis or key life decisions that and that may be surprising to some. We included a fact with impact, what we call a fact with impact. In this case, we included a fact that the 7 largest publicly traded U.S. health insurance companies reported a combined $71 billion in profit in 2024. That fact was positioned in the context of an individual story and helped to frame this around those misaligned financial incentives in the system, and remind people who were reading the story or listening to the story, this testimonial, about one of the key concerns that they have about the nature of the way in which our healthcare system is broken and driven by profit incentives. But we avoided a single villain. And this is an important point. Sometimes as advocates, we are quick to blame a single villain. In this case, we actually named a variety of key actors that are responsible both for causing the problems that we're facing and for solving the problems of high healthcare costs. And why that worked. It grounded leaders that read this story or listened to this testimony in the real human impact. It connected the individual stories to system level incentives. It made visible how often cost is part of those personal health decisions. And it added urgency and credibility excuse me, through the memorable data point. A lot of folks afterwards said, yeah, that 71 billion in profits, like that's notable. I remember that. That was a very sticky fact with impact. It also, we found, would be an even more powerful story if it had been tied to a specific policy solution or a call to action. Now, in the case of testing, we were conducting, this patient testimonial was not connected to a specific call to action for a piece of legislation, but this kind of story would be even more powerful if the speaker then made the case for a particular piece of legislation or policy change that they were working towards. So what I'd love to do now is share with you the tools, and my colleague will drop these links in the chat for you so you can access the full research guide. That includes all the research findings and the messaging recommendations. Thank you, Nadia, for dropping that in the chat. The second resource that we have for you is an at-a-glance guide. And we're also going to share that with you. If you can advance the slides, you'll see a quick picture of it. And that is just a kind of a cheat sheet for you, a reference guide. So once you've read through the research findings and you want a reminder of like, oh yeah, what are those messaging strategies, or what are the links to the messaging examples in the portfolio of content we tested, you can find all of that in our at-a-glance reference guide. And we hope that this makes it easy for you to take these recommendations and begin to apply this to the content that you are creating to activate and persuade policymakers and healthcare system leaders. And with that, I'll turn it over to Caroline.
Thank you, Carolyn. All right, I am so excited now to kick off our panel discussion. Just want to say thank you all for submitting the great questions that you did on your registration form. We knew that we couldn't have this briefing without answering some of those, and so we wanted to bring on some of our research advisors to answer some of those questions, and just want to say thank you to these advisors for serving as our panelists and being so generous with their time for us today. And one thing that we learned just over the course of this project is that there's so much to learn and be shared and cross-pollinate with each other across state lines. And so we're hoping that this gives a chance for that to happen today. So I'll quickly introduce our panelists and then ask them to say a little bit about themselves. So we have Selene Diaz of Health Access California, Dr. Myra Martello of the Florida Health Justice Project, and then Ann Wollison of Consumers for Affordable Healthcare in Maine. So panelists, I will ask you each to, again, just say a few words about yourself. And then I also want to know what you learned from this project as a research advisor. So that could be a big aha moment that you have, or you had anything that you're feeling particularly hopeful about after this research and in this moment, or something that you're planning to do differently in your work based on what you learned. So let's start with Dr. Martello from the Florida Health Justice Project.
Hey everyone, Buenas tardes. Well, I work at the Florida Health Justice Project, and I have to say that for this particular purpose, we worked in collaboration with Catalyst Miami around medical debt. So that was a great collaboration. And what I liked about this experience is that we have to find ways of building consensus. Like in a world that seems to be more polarized than ever, we have to find common ground and trying to stay away from the extremes. So yes, we know that the healthcare system is broken, but how do we approach people with an like a more provocative way of saying it's like, well, we fixed the big problem, right? Let's focus in something that is specific. So for me, that was sort of the hope. It's like not everything is lost. There's still, common humanity. So that was the part that I took away from.
Very powerful. Thank you, Dr. Marcello. Let's go to Ann Wallison.
Hi, everybody. I'm Ann Wallison, Executive Director at Consumers for Affordable Healthcare in Maine. Our organization serves as Maine's Consumer Assistance Program, and we also serve as the Medicaid Ombudsman. And I'm delighted to be here, and thank you all for joining us today. I think in terms of the question asked, the big aha moments and how are we planning to use this research in our work in the future? I mean, there's no question about how important personal stories are in our ability to activate leaders or policymakers who we know are with us on a number of policy initiatives. But we were really pleased and reassured about how using those stories enabled us to persuade policymakers who were hesitant at first for political reasons mostly, but who became very engaged and ended up being real champions in this work. For example, our Senate president, who had a lot at stake in terms of large health system opposition to our work around expanding access to financial assistance programs, for example. Personal stories from all over the state really helped her to feel comfortable and not alone in not only supporting our policy initiatives, but becoming a real champion. And then I think in terms of an aha moment, we were particularly surprised to see how personal stories actually helped us, in some cases, to neutralize opposition, where large healthcare systems said this isn't a problem, anyone who needs assistance can get it. But when we coupled personal stories with data that showed half of Maine families have medical debt, it really helped us to push back on the hospital narrative that there wasn't a problem and that something needed to be done.
Yeah, that's great. Thank you, Ann. Selene.
It's really great to be here with you all today. I'm a program manager with Health Access California, working at the intersection of communications and organizing, and informed by all of the policy work that our organization is doing. What stood out to me from this research project and what I find particularly hopeful is seeing that there is agreement that the system is broken, and knowing that there is skepticism about big changes. I think this presents an opportunity to message our work and solutions that address the short-term needs of our constituencies as a path toward a longer-term solution that is a more transformative structural change.
Appreciate that. Thank you, Selene. And thank you all. One of the major takeaways from this research was that it can be very beneficial to expand our networks of messengers. Particularly unexpected or surprising messengers can be very persuasive. And so let's stick with Selene. I would love to know, just looking ahead or even in the current moment, who are some of the messengers that you're particularly focused on building relationships with and, diversifying your storytelling and communications with by working with?
Yeah, at Health Access, we are really focused on bolstering our narrative change strategy by strengthening our storytelling infrastructure. This looks like ensuring that our network of messengers reflects the diversity of our communities. We're engaging labor partners, consumer advocate groups, and constituents from key districts in our state to support us in messaging the work and making sure that it's all rooted in the real life experiences of Californians within our healthcare system. We're currently putting all of this into practice with one of our statewide efforts to lower healthcare costs. This is in collaboration with our organizing team, and we're amplifying stories in regions with some of the highest hospital costs in our state, with a goal of moving forward more accountability in our healthcare system. And all of this work related to storytelling, having a broad-based coalition is vital.
Thank you. And now I want to go to Anne. Anne, tell us about some of the messengers that you're particularly interested in working with or are currently working with in Maine.
Yeah, thank you. We've built some really strong relationships with community-based organizations, community health workers in particular, and with staff at community health centers. They are much more open to sharing stories than they have in the past in terms of what they're hearing on the ground. And part of the reason for that is they don't feel alone in their storytelling anymore. In the past, they were hesitant to share what they were hearing, but now that others are starting to share their stories, personal stories, we're working with community health workers and community health staff, community health clinic staff, and sharing what they're hearing on the ground. We're also working more closely with substance use disorder and mental health professionals and larger membership organizations, for example, like ARP, which in Maine has a massive presence at the State House. And a lot of volunteers from all over the state who are willing to share their personal stories about what they've experienced in terms of medical debt. And finally, I can't emphasize the importance of incorporating the voice of businesses. We work very closely with an organization in Maine, and most states have one. It's called the Purchasers Alliance in Maine. And these purchaser alliances have membership of businesses that are purchasing health insurance for their coverage for their staff and their employees, and they're just finding it harder and harder to do so. So while we are not aligned on every issue, we are aligned on a lot of issues, especially issues related to how to prevent medical debt. And I guess one thing, we needed to know more credibility, but because these stories and the data that we share are becoming are so highlighted in news stories and through social media. I am surprised to hear we are hearing more from hospital systems who are reaching out to us, wanting to hear what we're hearing on the ground. And their feeling is they would rather try to work on some of these issues before legislation is actually introduced to address issues that we're hearing from Mainers and the struggles they have.
Super interesting. Thank you so much, Anne.
Cool.
All right. Now our next question. Earlier in your intro, Dr. Martello, you were talking a little bit about building common ground and just how important that is and how much of an opportunity we have to do that. And so some of the things we saw in this research are that there's shared common values like a commitment to quality care and coverage. There's this recognition that the system is broken, and lots of other opportunities to build that common ground. And so Dr. Martello, I want to hear from you. How can communicators use some of these shared experiences and shared values to build more effective messaging and have these more productive conversations in this moment, including across the aisle politically, especially in a state like Florida?
Yes. So I like to use the example of, Medicaid hasn't been expanded in Florida. That's like there's no agreement and a pushback. And yet we were able a couple of years ago to get Medicaid expansion for postpartum. So this is sort of the idea of like, we are not there. The ideal is to get here, but how do we get closer? So sometimes, like a couple of years ago when we went to Tallahassee, Recently, they have pushed back the federal government the idea that medical debt wouldn't be in having a direct impact in the credit scores for people. So that was pushed back, but we had the opportunity to go to one of the state representatives, and she had a constituent there. So it was different when she heard that that particular constituent had lost her house because of medical debt. So that changed, like we didn't get the bill passed, but it's sort of building the case to say, okay, where do I find common ground, even if it's limited? So same example with Medicaid. Like we haven't expanded Medicaid, but at least we were able to get the expansion for postpartum for pregnant women or pregnant people a year after they delivered their baby.
That's great. Thank you for that. I want to go back to Anne, and same question here. So Anne, I'm curious, in your perspective, how do you think communicators can build on these shared experiences and values to reach across the aisle politically?
Yeah, thank you. I mean, we have continually heard from large hospital systems that now is not the time. They can't possibly do any more to control cost or improve access to financial assistance, for example. But when you think about the messaging strategy slide that Carolyn discussed just a few minutes ago, and the different types of content, including most probably from my perspective, those personal stories, coupling it perhaps with data or other tools you might have in your toolbox, we have found that that has helped us emphasize that we can push back. Mainers are having to make tough choices, and we need to hit a balance. And I was so surprised by hearing, our health coverage committee members from all parties emphasizing our data. We just heard from somebody last week about how they were denied financial assistance even though they were eligible for it. And we just heard a news story last week about how half of Maine families are struggling with medical debt. Something needs to be done. And I guess my point is that there's always this tension between incrementalism and large change, but no matter what, we have to keep the door ajar. We have to keep it open with all the players, all policymakers. And the way we are keeping that door open is by sharing stories, listening to the concerns policymakers have, and then supporting some of the incremental changes we want to make with data. And it has really helped us move forward policy initiatives in Maine during a really difficult time. I hope that's helpful.
Yes, very helpful. Thank you so much. All right, I think we have time for one more question. And I think this is a great one to end on. So, several of the health system leaders and policymakers that we spoke with are feeling this pressure on the system, right? And they're seeing this boiling point, this sort of momentum, this opportunity that's coming for more drastic change. Sometimes we would describe the Overton window is shifting in terms of what's possible. And so with our last few minutes here, I want to go back to Dr. Martello and hear your thoughts on how we as a movement might contribute to building that momentum in this moment of opportunity, and just what you think are the biggest opportunities right now.
Yeah, I think like elevating the voices of other people, like we hear the voices of patients and we always need those voices, but I think it's also bringing the voices of doctors, right? Like how are they impacted when their patients cannot have access to the healthcare that they need? That has also a direct impact on them. So also from the business perspective, as Anne said, like this is not only, it's not only impacting the users of the system, but there are other people that are also being impacted by those, the lack of changes and, sort of reform that we need. So it's always highlighting what other voices we are not seeing or hearing and elevating those voices.
Yep, really important point. All right, Selene, let's go to you. Same question here. What are you seeing as the biggest opportunities in the moment, and how might we as communicators help leverage those?
I think more and more people are resonating with messaging that names the root cause of inequities, not only in our healthcare system, but just overall. And this is an opportunity to craft messaging, pointing out these root causes and advocate for policies that might have not been considered or centered years prior. But given where we are now with HR1, we are in a much different place. And so our menu of solutions is starting to reflect that. California, for example, is now taking the first concrete step toward requiring the largest corporations in our state to pay their fair share when they shift healthcare costs for their workers onto Medicaid. So the momentum for something different and more accountable is there. And it is an opportunity for us to message the work in a way that inspires hope and continues to uplift solutions like this one.
Yeah. Thank you so much for that. I think it's important to keep that hope. And so just really appreciate you all sharing what you're doing that's working, what you've learned. I know I am feeling inspired by you all. And so thank you again for taking the time to speak. In our last couple of minutes, we want to turn it back over to Community Catalyst. So I'm going to turn it over to Colin Roosh from Community Catalyst to say a few words and close us out.
Great. Thanks, Caroline. And thanks again to Wonder for Good, as well as our panelists and all the staff who make this briefing possible. I hope that the research and findings presented today are additive to your advocacy strategies in the field and as we all work together to advance a more equitable healthcare system. I think this research underscores the ways in which we can navigate what often feel like roadblocks in our collective work by cultivating new and influential messengers for change. To be clear, that doesn't mean that our role as advocates is to never engage in difficult conversations with or hold accountable policymakers, health systems leaders, or others who wield power and influence on our healthcare system, but really rather to find new ways to make proactive change more resonant to them in a way that allows them to see their role in making that change. We heard today from some of our panelists that we don't always find full alignment with any given stakeholder, but we can persuade them and move them to action by speaking to common values, demonstrating that there are solutions they can be a part of, and empowering them to wield their power as one of many entities who has not only contributed to the state of our current system, but who can also play a role in improving it because they too likely agree that the system isn't working in its current form and may also feel that the path forward is daunting. So I hope that moving forward, we can continue to test these recommendations with all of you, combining these persuasion tactics with individual and community stories, evidence-based research, and traditional organizing tactics that continue to shift power to the people most impacted by the shortcomings of the healthcare system today. Thank you all very much.
Thanks so much, Colin. All right. Thank you all again for joining us today. Appreciate you spending the hour here. And with that, we will go ahead and end the webinar. Thank you so much.
Thank you.
Bye-bye.